All right, good evening, everybody. Once again, this is a American Foregut Society webinar. We thank everybody for a really fantastic year. This is going to be our last webinar of the year to give everyone December for the holiday seasons. We'd love to thank every single audience member, speaker, and participant throughout this year. We will reboot for a whole new schedule next year. We have two great speakers tonight. We're rounding out the topic of Barrett's esophagus and early esophageal cancer. The last webinar touched on the diagnostic aspect, and tonight we're going to be talking about the therapeutic aspect. So we have two fantastic speakers. I'd love to start by introducing our first speaker. We have Dr. Vivek Kaul, who will be speaking about multimodal endotherapy for dysplastic Barrett's and esophageal neoplasia. He's the Cecil Watson Professor of Medicine at the Division of Gastroenterology and Hepatology at the University of Rochester Medical Center, where his clinical and research interests and medical education efforts focus around therapeutic endoscopy and endosurgery, interventional endoscopic ultrasound, ERCP, and pretty much all endotherapy based around Barrett's and early esophageal cancer. He has a very refined expertise in complex interventional endoscopy procedures, especially as it relates to GI-centric cancers. He's a PI in several national and international trials on endoscopy in both pancreatic and foregut and esophageal diseases, and serves on multiple national committees for both the ASGE and the AGE, chair of innovation and technology committees, as well as the chair of the EUS Special Interest Group for the ASGE and chair of the World Gastroenterology Organization's Endoscopy Committee. Very involved. We're very excited to have him here. Again, speaking on multimodal endotherapy for dysplastic Barrett's and esophageal neoplasia. So thank you so much for your time.
Thank you, Steve, for kindly inviting me to speak here, and particularly pleased to be here with Prasad and on behalf of the AFS. This is an important topic, and we've tried to divide it into two parts: standard therapy for Barrett's and then some of the newer modalities. So I'll begin by starting my slides here, and then we'll do questions after both the talks. So my specific topic here is multimodal therapy, multimodal endotherapy for dysplastic Barrett's and early esophageal neoplasia. And my emphasis will be exactly on highlighting the key principles of Barrett's endotherapy, especially as it stands in 2021 going forward. The objectives are to identify which patients are best suited for treatment, emphasize really the concept of multimodality treatment from an endoscopic perspective, review the indications for endoscopy vis-a-vis surgery. I will try to highlight, as usual, some controversial topics and review some of the limitations and challenging scenarios. A very important point to highlight in modern endoscopy, Barrett's endotherapy represents one of the earliest paradigm shifts in endoscopy versus surgery. And really, we've transformed the care for a significant percentage of patients in this realm, from esophagectomy, which is probably one of the most morbid surgical procedures, at least traditionally speaking. Now things have been refined significantly now, but as it stood back in the in the 90s and the early 2000s, esophagectomy was a significantly morbid procedure, and we converted a lot of those to endoscopy and that type of paradigm shift. So that's important to note. The United States definition of Barrett's includes both endoscopic and pathologic correlates, where you need to have at least a centimeter of columnar lined epithelium, along with specialized intestinal type goblet cell metaplasia on pathology, and this definition is different in Europe. Barrett's is a precancerous condition, and there is a finite risk of progression, which is hotly debated, but it is real. Now, this is kind of sort of the high-level view of the natural history of Barrett's esophagus in the worst-case scenario, if it's allowed to run its course. Obviously, the vast majority of patients are non-dysplastic and will remain such throughout their lifetime. That's an important principle to keep in mind. However, a few of the patients will be found to have indefinite for dysplasia. We can have a conversation on that in the Q&A. Low-grade dysplasia is an interesting entity, and we'll talk about that on its own. But of course, high-grade dysplasia and intramucosal carcinoma, there's no doubt that they warrant treatment. And this is the area where we have made the most progress in. The ones in red, of course, are invasive carcinoma, locally advanced carcinoma, and metastatic disease. In all of these three, endoscopic therapy has a limited role or no role. So the first question that comes up is, who are the patients who should be treated? So it's very clear from a multitude of guidelines, both sides of the Atlantic, that surveillance really is the mainstay for non-dysplastic Barrett's patients. Again, something that has been hotly debated over the years, but the guidelines still recommend that in a forceful manner. A certain percentage of low-grade dysplasia patients will also be eligible for surveillance, and that stands true in the guidelines. But endoscopic eradication therapy is reserved for certain patients with low-grade dysplasia, almost all patients with high-grade dysplasia, and certainly for those with early esophageal cancer, and a super selected group of patients with superficially invasive submucosal cancer, which we'll talk about. Surgery, of course, is the mainstay for invasive disease, as I highlighted earlier. Now, this is an interesting study about low-grade dysplasia. There's low-grade dysplasia, and then there's low-grade dysplasia. So this is really one of those areas where I think still there is relatively poor understanding in the general population. So this is a study from a few years ago, a very elegant study that looked at a number of low-grade dysplasia patients, about 300 of them, and they confirmed the diagnosis with expert pathology. And when expert pathology confirmed the diagnosis, a very high percentage of patients, nearly a third of those patients in that subset, actually had progressive disease, which was more serious than just low-grade dysplasia. In the vast majority of patients, roughly 70% of patients, the low-grade dysplasia was actually downstaged to a basically non-dysplastic epithelium. So therefore, one of the first recommendations that comes out is that when you have a situation with low-grade dysplasia, it really should be confirmed diagnosis, ideally by a GI pathologist. And again, the emphasis is the fact that there is a lot of inter-observer variability still, especially in those people where there is less experience with Barrett's. Now, the question is whether we should do ablation or surveillance. The controversies in low-grade dysplasia is the purported relatively low rate of progression in the vast majority of patients, especially those where the dysplasia is of uncertain nature. There is a lot of variation, but the considerations for treatment really emerge when you confirm this disease, this low-grade dysplastic state, when especially the patient has a familial Barrett's type of scenario or a family history of esophageal cancer, especially early esophageal cancer in the family. One does have to take into account the comorbidities and age of the patient, because life expectancy overall vis-a-vis the impact that low-grade dysplasia may have and how fast or quickly the dysplasia may progress has to be factored, and that's a very individual decision. But certainly persistent and multifocal dysplasia in a long segment Barrett's warrants attention. Those patients who have nodular segments of disease with raised areas certainly should have resection as both a staging procedure as well as treatment. And many of these patients with low-grade dysplasia that have bulky disease, a thickened esophagus, nodular lesions, they probably harbor a more serious pathology. At the end of the day, almost in all patients that I see with low-grade dysplasia, it really involves a very intense shared decision-making, and patient preference and motivation is to be taken into account. So this is an important slide which I wanted to highlight. Now, how do you determine therapy, which is appropriate therapy when you once decide that the treatment is to be done? So basic principles of esophageal endoscopic or eradication therapy are listed on this slide. Resection of all visible lesions, and this is a board question on the GI boards, ablation of residual Barrett's epithelium, and complete eradication of dysplasia. And I actually make a case for complete eradication of intestinal metaplasia, as I will highlight why that is important down the road. So the steps to ensure the best practices in data-driven interventions in Barrett's are highlighted on this. Now, this is where Sachin Vani and his group and their work early on a few years ago really made a big case for high quality index examinations, mapping biopsies, spending time in the esophagus, very similar to what was purported in the colon about 2 decades ago. And the adherence to or lack thereof with the Seattle protocol can be discussed in the Q&A session. Endoscopic resection for raised lesions is an important principle. I already mentioned that. Expert pathology review really cannot be overemphasized, and there are these resources available nationwide if one doesn't exist in your center. Low-grade dysplasia treatment should proceed along the caveats that I mentioned in the previous slide, and there is no doubt or no controversy that high-grade dysplasia or intramucosal cancer warrants therapy. The T1B pathology or above really warrants interdisciplinary or multidisciplinary tumor board type discussions. Some of these patients will be eligible for endoscopic therapy, but the vast majority of invasive cancer is beyond the reach of the endoscope at this time. So once we know that which patients are to be treated and what are the appropriate interventions, then how do we decide which option is best? So for nodular Barrett's for resection, EMR is certainly an option and probably is still the mainstay of therapy. ESD has emerged as another option. I'll speak about band and cap EMR, and Dr. Iyer will highlight ESD. For flat Barrett's, of course, RFA was the first paradigm. Cryoablation with liquid nitrogen and carbon dioxide cryotherapy emerged about 15 years ago. And more recently, we have newer modalities, which Dr. Iyer will go into. Other modalities like argon plasma coagulation, multipolar electrocoagulation is something that has been used in the Far East and in Europe, certainly in other areas where there are resource limitations and other cost measures that impact medical care. Many patients will end up requiring multimodal therapy. This includes the concept of touch-up RFA, touch-up APC, and so forth. And we've learned that from our colleagues around the world. And I'll highlight the importance of that down the road. The patients must commit to a timely interval-based serial treatment session protocol. And especially this becomes more important for long segment Barrett's and for those patients who come to referral centers from far away. This is something that needs to be highlighted in the initial visit. And then finally, of course, the importance of acid control cannot be overemphasized in this group. So for EMR, the options are listed on this slide. Our European colleagues introduced the concept of widespread EMR and complete Barrett's eradication with EMR. I don't believe this is practiced that much in the States, but certainly multi-band mucosectomy and band and cap EMR are practiced in this country. And this is an example of what we call band EMR. This is basically a variceal banding type kit, which is used. This is a dedicated kit. The only main difference is that it has a dedicated snare that goes through the channel of the scope. So here we have the creation of the pseudopolyp. This typically does not require any submucosal injection. The pseudopolyp has been created, and our German colleagues long ago showed us that resecting this below the band is actually quite safe. And that's the preferred approach, although you could go either way. Certainly, if you're early on in the experience, it might be more comfortable to go on above the band. So once the lesion is resected, you inspect the base. Perforation is extremely uncommon in this scenario because the banding device is not designed to capture muscle. In fact, that's one of the limitations of the banding device, that when you have scar tissue or when you have invasive lesions, the band actually will not work. This is the example of the cap EMR. This is, I believe, a relatively less practiced intervention. This is a dedicated cap kit. I'll just hold that for a second. This is the EMR kit that is available. I believe only one manufacturer has that. These caps come in hard and soft and straight and oblique orientations. And it is a technique that does require a little bit of learning and getting used to. A submucosal injection, as demonstrated here, is absolutely mandatory. Otherwise, it will most likely create a perforation. So here are the steps. This is a large lesion at the GE junction. And the snare is dedicated and seated in the cap. And then we have already pre-injected with the solution of your choice. Saline is okay, but others can be used as well. And the concept of the pseudopolyp creation is very similar to the band EMR. The only difference is you have a seated snare already that will then capture the pseudopolyp in the moment, and then standard endocut-based cautery is applied. Now, this is where this is a little different than the band EMR technique, but is able to actually resect lesions greater than 1 centimeter and up to 2 and 3 and 4 centimeters with the contiguous approach. So this is the first of 2 contiguous resections. You can see this lesion is extending into the cardia. And here you have to be more careful because the cardia mucosa is softer, and it's imperative to inject and separate the muscle layer. And that is to be done with every step. Here is the seating of the snare, which is a more difficult portion of this procedure, and does take getting some experience both on the technical side as well as on the provider side. So here's the second pseudopolyp. And this is a contiguous resection with no bridge areas that are left. And you can see here it does take a fairly sizable chunk of tissue. And the field that is left after this type of resection is very similar to an ESD. So if you're not performing ESD and want to be done in about 10 minutes and follow these steps meticulously, that's the kind of field effect you can expect, which is very, very similar to an ESD defect right there. So CAP EMR is definitely an alternative, but again requires some training and some comfort. So endoscopic ablation beyond resection is highlighted in the next few slides. Obviously, the principles here involve complete obliteration of the at-risk Barrett's mucosa. A variety of approaches are available now. RFA was the initial one. We have cryotherapy in different forms available. And of course, our cautery-based interventions are still available in most units. And the next talk will speak more to the balloon, ESD, and hybrid APC type interventions, but I'll stick to the more standard interventions. There are some contraindications to ablation. This is listed in the IFU, pregnancy, EOE, obviously frank esophagitis, and so forth. So one has to be aware of those. The ideal ablation technique balances uniform mucosal injury with the desired depth, but not going too far intramurally, so that stricture rates are low, the patients tolerate it well, and the overall device and the technique have an excellent safety profile. For the most part, all ablation techniques today fulfill the vast majority of these criteria. This schematic here demonstrates the concept of depth of injury. So with the RFA, as expected, as intended, the depth of injury is quite superficial. EMR goes down to the level of the inner circular muscle fibers almost, if it's well performed. Cryotherapy on the day of the injury actually goes down deep into the muscle, and then the inflammation heals back up. And it works in a very different way than thermal energy and doesn't really disturb the collagen matrix too much. This is a seminal paper, which is the RFA sham trial published several years ago, which basically first highlighted in a randomized controlled trial fashion at level 1 evidence the importance of RFA in ablation. RFA was a technology developed about 20 years ago. It's a bipolar energy delivery system, and for the most part has been highly efficacious with the dysplasia eradication and metaplasia eradication in these ranges for the most part in majority of studies. Of course, with longer term follow-up, these numbers do drop a little bit, as I'll show, but this was the first time this paradigm was firmly established. RFA comes in two basic platforms, which is the balloon therapy depicted here for longer segment treatment, and the paddle-based approach for short segment Barrett's and focal treatment. These videos demonstrate RFA application. On the left side is standard application with one of the standard paddle devices. You can see the coagulum developed here on the mucosa under direct vision, and you can move in a contiguous fashion in a very controlled way. And then for the first application, and then moving on here with the second one, with the mucosal scraping, which is a standard part of the technique, and then you apply the second ablation for that particular session. Some have argued that you can go without mucosal scraping. We can talk about that in the Q&A session. Now, this is an important trial a few years ago, the Euro 2 trial, which demonstrated the combination of multimodal approach here with EMR and RFA. This was a multi-center trial with more than 100 patients, 90% of whom had EMR, which is actually a very high percentage of EMR with a median follow-up just over 2 years. So the numbers are here with complete eradication of neoplasia with this approach in the 90s, and for intestinal metaplasia in the high 80s. And no matter which way you cut it, this was demonstrated to be a very highly efficacious therapy with combining EMR with RFA in a prospective manner. This is another study that shows the long-term outcomes, the SURF study. Total median follow-up was upwards of 6 years. Patients coming in with high-grade dysplasia and cancer undergoing RFA therapy. There is definitely, a relative recurrence, long-term follow-up in about 10% of patients, but the vast majority of patients had a significant risk reduction in neoplasia progression, and this was a good long-term study to show the robustness of RFA therapy in the long term in the low-grade dysplasia population and in the dysplastic population. Moving on to liquid nitrogen spray therapy, cryotherapy. This was developed again about 15 years ago. This is liquid nitrogen at minus 196 degrees centigrade, and essentially is a catheter-based delivery system through the scope. The typical freeze cycle for standard flat dysplastic Barrett's is 30 seconds, and then the thaw cycle in between 2 or 3 freeze applications ranges from a minimum of 45 seconds to up to 2 minutes. It's extremely well tolerated and has been widely adopted as well. This is typically how cryotherapy works. This is a through the scope catheter. This is being done in narrowband imaging, so we can actually see the segment well. The cap helps with the field visualization, although with multiple applications in one session, that can be an issue. And there are techniques to avoid that, just like we have with hemospray and such. So the primary indications include all those indications that are applicable for RFA, but especially useful in abnormally contoured esophageal lumens, especially where apposition of the balloon can be difficult. Patients with bleeding disorders, it's a relatively better tolerated and been demonstrated to be safe. Of course, has been initially used a lot as salvage therapy in refractory Barrett's, where RFA and other modalities were not useful. Then, of course, there's enough literature now to show that it's also effective for palliation and for subsequent treatment in invasive cancer. So this is some data on liquid nitrogen spray cryotherapy. This is a single center retrospective study with 3-year and 5-year analyses here for a sizable number of patients. And again, you can see here that the eradication of dysplasia and intestinal metaplasia, even at the 5-year stage, is pretty good. And this actually was one of the studies that really looked at long-term outcomes. And even though recurrence rates exist, as they do with every modality, the long-term treatment effect is quite successful. This is actually an important paper. It's not yet published because the study is still going on. This is the largest US multi-center real-world prospective registry of liquid nitrogen spray cryotherapy in 15 sites with at least 1-year follow-up, and the primary outcomes are listed here. And again, in the National Registry of the real-world users, both academic and private settings, spray cryotherapy achieved very high intestinal metaplasia eradication rates and dysplasia eradication rates. And this is not just expert centers, this is the real world as they come. So that's pretty powerful, and this manuscript will be published once the 5-year follow-up is completed. That'll be very important information. This is data from our own center. This is an 11-year follow-up of patients with dysplastic Barrett's and early esophageal cancer. This is basically the time that we really looked at multimodal therapy. About half of the patients underwent touch-up RFA, in some cases also APC, and a very high percentage of these patients went initial resection and then subsequent resections. Mean number of sessions was 3, and mean follow-up was about 5 years with a very low adverse event rate and very, very high numbers in terms of CEIM and CED. So this is another very long-term example of durability and robustness of treatment. This is an interesting slide. This is a lot of times people ask RFA versus cryotherapy. So here's a validated pain score based study from 4 centers, almost 100 patients, comparing liquid nitrogen with RFA. So chest pain is one of the common morbidities with ablation, and with cryotherapy, both the immediate post-treatment pain, 48-hour pain, and 3 weeks post-treatment pain indices were significantly lower with the cryotherapy arm compared to the RFA arm, and that's quite well acknowledged in the community at this point. So when you're making treatment decisions and pain comes up, this may be an important data point to keep in mind. So what are the complications of endoscopic eradication therapy? Well, there are several that are mild to moderate. Serious complications are rare, such as perforation and emergency surgery. But again, in older patients, cardiopulmonary events can occur just like in any other endoscopy. Esophageal strictures have remained stable at the 5 to 7% range, a little bit less with the cryotherapy arm, a little bit towards the higher side with the RFA arm. Report of mediastinitis, which is managed medically. So overall, these are challenging situations, and we can discuss some in the Q&A session. Persistent esophagitis is a problem. Difficult anatomy can be a problem. Scar tissue from prior therapy, from repeated EMRs, can be a problem. I find patient adherence and compliance can be an issue if there is a relatively low literacy or not that much in-depth counseling and information up front. So that can be an issue that can impede the treatment paradigm. Older patients, we have looked at and reviewed the literature on that, as I will show later, and refractory Barrett's esophagus, which remains a challenge at this time. This is an example of a challenging upper esophageal anatomy. You can see here a savory guide wire is being used to navigate a difficult osteophyte complex. I highly recommend this because if there's a problem getting the paddle-loaded gastroscope in the esophagus, that's not something you want to fight. because a significant trauma in this location is very difficult to manage endoscopically. Although the vast majority of these patients, if they have a perforation in the pharyngoesophagus, they can be managed conservatively, but some of them will require a surgical repair, and that's not a good day for anybody. So how important is surveillance after endoscopic eradication therapy? So this study here is an important study published in Gastro, looking at a 5-year follow-up of patients treated with standard endotherapy. 92% of them achieved complete eradication of intestinal metaplasia, which is a very high percentage, but 32% of them had recurrence of Barrett's or dysplasia in long-term follow-up. So this is an important tenet, which is why we really have to continue surveillance for these patients until we have a different paradigm that emerges down the road. This is another study by the same group looking at some type of an intelligent algorithm based on experience and data. So this is the US RFA registry, and they basically recommended that for low-grade dysplasia, which is a starting out pathology, a 1-year, 3-year, and 5-year follow-up is reasonable as long as you've initially achieved intestinal metaplasia clearance. But for a high-grade or higher pathology, a more closer interval upfront is recommended, because these are the people who tend to recur more and have more serious progression if not monitored closely. The point of this study was that a significant reduction in endoscopy surveillance, morbidity, and cost can be achieved following this algorithm, and that might be something to consider, especially in patients who are not willing to come that often. How do you manage persistent Barrett's after ablation? That's another question that comes up. So refractory Barrett's is defined in most studies as 3 sessions. I don't always agree with that, but 3 sessions and you still have Barrett's. You know, long segment Barrett's typically will require more sessions, but we can debate that in the session. Our strategy here is to maximize acid suppression, fix any large hernias if we can. Then the question comes is, do you continue the same modality, or do you go for a different modality, or one of the newer therapies such as Endo Rooter and stuff that Prasad will go into? Do you combine multiple endoscopic modalities? Or do you refer them to surgery, or what do you do? So some of these options are listed here. Resection becomes important in dealing with some of these recalcitrant islands and lesions. But this is a challenging area in the post-ablation scenario where residual Barrett's remains. And in the final few slides, what are the indications for surgical therapy? Well, there are more than a few. Submucosal invasion, which is T1B, that is beyond the SM1 level, especially in cases that are poorly differentiated with lymphovascular invasion. Nodular segments that are refractory to standard therapy despite all good efforts, it's perfectly fine to invoke surgery. Lesions that are not amenable to endoscopic resection, these are lesions below strictures, they're difficult to get to, they're scarred down, where EMR and ESD are not practically feasible options. A non-compliant patient with the serious pathology is someone you don't want to mess around, and you want to invoke multidisciplinary management early on. And of course, esophageal anatomy really sometimes dictates what we can or cannot do for our patients. I believe that a multidisciplinary approach is really key in this realm. I think we need to have endoscopists who have approached Barrett's as a comprehensive toolbox with potentially all techniques and devices at their disposal would be the ideal scenario. Great partnership with thoracic surgery for a variety of reasons. And obviously, a key element is the GI pathologist, which I mentioned early on in my talk. And sometimes when developing these programs, you have to work hard at investing institutionally in that space. And then, of course, a highly active and deliberative tumor board is seminal to the success of a program. Take-home points. Multimodal therapy for Barrett's has really raised the bar in terms of achieving very, very high rates of long-term intestinal metaplasia eradication, which should be really, in my mind, the bar. Recurrence rates do approach 30%, and they correlate well with index pathology. So the more serious the index pathology, the more likely the patient is to recur. Patients will require ongoing surveillance at this time. Acid control is really, really crucial for the best outcomes. Serious complications are uncommon, but mild morbidity does exist, especially in the older populations. Challenging scenarios still exist, as I defined earlier. Indications for surgery should be well understood, and these decisions need to be made early so you can salvage the patient and approach cancer-free survival down the road. And I think the importance of a multidisciplinary approach can never be overemphasized. Thank you for your attention. And we'll take the questions after the second talk.
All right, well, thank you very much, Dr. Kaul. It was a really fantastic talk, poured through a ton of awesome data, really important literature, made it very succinct and very, very simple. So thank you so much for your time. Again, we'll save the Q&A for the end. We'll move on to our next speaker. Very excited to introduce Dr. Prasad Iyer. He completed his residency at the University of Wisconsin. This is followed by a fellowship as well as a master's in science at Mayo Clinic, where he currently is professor of medicine and the director of the esophageal section of GI and hepatology. His clinical and research interests are focused on early detection of Barrett's esophagus and endoscopic therapy of early esophageal cancer, especially using biomarkers. He's a very sought after speaker. He has over 200 peer-reviewed manuscripts. He's the associate editor for gastrointestinal endoscopy, and we're very happy to have him here. So he'll be discussing ESD as well as newer ablation modalities for Barrett's esophagus and early esophageal cancer. So thank you so much for your time.
Thank you, Stephen. This is a great opportunity, and thank you to the AFS for the kind invitation. So I'm just going to begin my sharing my talk. Are you able to see the screen?
Yes, we see your screen.
Okay, let me just
you
switch
can,
this.
yeah.
Is that
good?
good?
Just switch over. Yep, there you go. Perfect.
Okay, awesome. Well, thank you. So Vivek is always a tough act to follow, but I'll do my best. So I think Vivek has gone through the front end of Barrett's endotherapy, where he's very admirably gone through the routine modalities that we use. And as he mentioned, these modalities are very successful. There's a high rate of remission of intestinal metaplasia, dysplasia. And my job, maybe in the next 10 to 15 minutes, is to highlight some of the newer modalities for Barrett's esophagus endoscopic eradication therapy. So these are my disclosures. And in terms of the outline, I could divide my talk into two broad sections. The first is on resection. I'll spend some time talking about endoscopic submucosal dissection and also touch on a newer resection modality called the Endo Rooter, and then switch to some newer ablation modalities, and I will touch on Cryoballoon as well as hybrid APC. So what is endoscopic submucosal dissection? It is basically an endoscopic resection technique with principles that are very similar to that of cap-assisted endoscopic resection, in the sense that we have to identify the lesion with a careful examination of the Barrett segment. These are typically larger lesions, and you would mark the margins of the lesion that you want to resect with cautery. Similar to cap-assisted endoscopic resection, you would inject submucosally to lift the lesion off of the muscularis propria. Now, in distinction to cap-assisted endoscopic resection, the cap itself is not used for the resection, and there is no suction that is applied. Instead, you would use a variety of endoscopic knives to make an incision, followed by exposing the submucosal plane and dissecting within the submucosal plane to complete your resection. And this allows a larger lesion to be dissected en bloc. Now, this technique is something that was actually developed and popularized by our Japanese colleagues and developed primarily for squamous cancer. However, its application to Barrett's and esophageal adenocarcinoma has gained increasing acceptance. So I'm going to highlight a couple of multi-center studies which have looked at the role of endoscopic submucosal dissection. This first series was published in GI endoscopy now about 4 years ago from Europe, where a total of 143 patients underwent resection. And as you can see, there is a high rate of en bloc resection. Almost 80% have an R0 resection, which basically means that the resection is curative. So you have negative lateral margins, you have negative deep margins with a fairly low adverse event. And at least in this paper, they talked about a learning curve of about 30 cases, after which the learning curve will flatten. This was actually co-published in the same journal, same edition of the journal, with a simultaneous multi-center cohort study from the United States, where a smaller cohort of about 46 patients underwent ESD in Barrett's, and again, high rates of end block and R0 resection, as well as low adverse events rates. Now, something to always remember is that ESD is, though its principle is the same as cap-assisted endoscopic resection, it is a technically more demanding procedure, takes longer time, and typically tends to have a higher complication rate. Now, so obviously this raises the question as to what do we gain by doing an ESD versus an EMR? So this was a randomized study which was published in Gut again about 4 years ago, where patients with lesions up to 3 centimeters were randomized to either cap-assisted EMR versus ESD, as long as the lesion occupied less than 50% of the esophageal circumference and there was no evidence of massive submucosal infiltration. And this was a relatively small study, 20 patients in each group. And as you can see very clearly, ESD takes about twice as long as a cap-assisted EMR to do. And it does seem to have a higher rate of perforations. However, as you can see, the rate of R0 resection was much higher in the ESD arm compared to the EMR arm. However, rates of surgery, achieving complete remission of intestinal metaplasia, and recurrent IM were comparable, though, as I said, the sample size was small, and hence these outcomes were, the trial was not really powered for these outcomes. Now, we looked at this question in a little bit more detail, where we looked at 2 cohorts of patients. The first cohort underwent ESD, followed by ablation. The second cohort underwent cap-assisted endoscopic resection, followed by ablation. And our primary outcomes were histologic outcomes. So complete remission of dysplasia, complete remission of intestinal metaplasia at 2 years. And not surprisingly, what we found, as you can see in this Kaplan-Meier curve here on the right, is that the ESD group reached dysplasia remission faster than the cap-assisted EMR group. However, when you follow the resection with ablation, the rate at which they achieved complete remission of intestinal metaplasia was not different at 2 years. And indeed, on a multivariate analysis that you can see here, the real predictors of reaching complete remission of intestinal metaplasia, as Dr. Kaul mentioned, which should be our goal in all patients undergoing endoscopic eradication therapy, was really the length of the Barrett segment and not the assignment to ESD or cap-assisted EMR. A question that still remains somewhat unresolved is that, is recurrence going to be any different in patients who undergo ESD? This is the primary reason why the Japanese have pushed for ESD in squamous cancer, in gastric cancer, as well as in colorectal cancer. And that question, I think, is still to be resolved. So what is the current status of ESD in the management of Barrett's neoplasia? As I've shown you, these manuscripts, as well as other investigators, have shown that ESD is safe, it is feasible, particularly in the hands of expert endoscopists. Where should it likely be preferred to cap-assisted endoscopic resection? Probably for larger lesions, lesions which are maybe more than 15 to 20 millimeters, where margin negativity might be difficult with a cap-assisted EMR, particularly the lateral margins. If you're suspecting extensive submucosal invasion, particularly in depressed lesions, so Paris classification 2C, perhaps. And then if you are anticipating scarring, so lesions that recur after ablation or after radiation, might be easier to resect with endoscopic submucosal dissection. So I would still argue that cap-assisted EMR remains a very viable option, particularly in combination with ablation. And I do think that some of the jury is really out in terms of where these two techniques best reside. Let's move to the second newer modality of endoscopic resection. This is called the Endo Rooter. This is a relatively new kid on the block. It is a catheter-based endoscopic resection system. And the catheter can actually be advanced through the therapeutic channel of the endoscope. It has a rotating blade with a 2 millimeter window and has 2 rotation speeds. And as the blade rotates, it is actually connected to a vacuum. So the bits of tissue that are resected are actually sucked into the tube, and it is combined with an irrigation device as well. So the water is constantly flushing the cut pieces of tissue into this receptacle, which collects these pieces of tissue, which are in about 2 millimeter pieces, similar to that of forceps biopsies, and technically can be sent for histopathology. This is what the defect looks like. And of note, you would typically inject submucosal saline with maybe some methylene blue to lift the mucosa off of the muscularis propria and protect it. So this is a larger defect, and this is how the technique is performed. Now let's go to some results. This was a smaller case series that was published about 3 years ago, and it had 14 patients with T1A, T1B superficial cancers. After their endoscopic resection, mean Barrett's length was C2M7, and a fairly large Barrett's area was resected by expert endoscopists. Something to note is that almost 2/3 of these patients had moderate pain, and almost half had intraprocedural bleeding, which could be controlled endoscopically. Most of the resected area did get replaced by squamous epithelium. And again, there was no stenosis at 3 months, which is good news, because this might be applied to refractory lesions. But most of the patients did not reach CRIM at 3 months, not surprisingly. So some things to note about the Endo Rooter is that I think the experience overall is still limited. It is likely going to be applicable to smaller areas. It can lead to deep resections because really it is this rotating blade, and you have to take a lot of care to avoid damaging the muscularis propria, which can quickly get exposed. Pain and bleeding are common, and it is unclear if CRIM can be achieved. Let's move on to newer ablation modalities. This is the first one I'd like to talk about. This is called balloon cryotherapy. So Dr. Kaul talked about liquid nitrogen spray cryotherapy. Here, the differences are as follows. The cryogen is actually nitrous oxide, and it does not get as cold as liquid nitrogen. So that is the first difference. The second difference is that unlike spray cryotherapy, the nitrous oxide is actually deployed in a closed system, in the sense that it is expelled through this hole in a longitudinal diffusion catheter, which also rotates, and it is confined within the balloon. So it is deployed inside the balloon, and it is aspirated via the balloon. The catheter can actually be passed through the therapeutic channel of a therapeutic scope, or you can pass it over the scope with a over tube-like device. The other part of the system is a handheld handle, and the third part is the nitrous oxide canister. So this is just an example. I have a video on the next slide. This is just an example of the endoscope looking through the catheter and the spray coming out from the diffusing catheter. And unlike the liquid nitrogen spray, there are no freeze-thaw cycles. This is a single 8 to 10 second spray one time. And I'll show you a video here. So again, as you can see, I'm looking through the endoscope. This is on narrowband imaging, and this is your catheter, and that's a Barrett's island. And I'm doing a test dose, and I'm wanting to make sure that I'm actually in the right position. I want to rotate a little bit, and as you can see, I'm now rotating. And once I'm happy with this, with a single press of the pedal, I can do a 10-second spray. It basically is a single spray, and once the spray is done, the treatment is done. And then you basically want to target the island on the contralateral wall, and again, you can rotate with the foot pedal, and then you give this a 10-second spray again. So it's a fairly simple way of deploying the treatment. Now, what are some limitations? So at this point, there is no circumferential treatment balloon. So if you have a long, let's say C10 M12 Barrett segment, then treating such a long segment with just a focal device is going to be challenging. And a circumferential balloon is being developed, we will see how that does. The stricture rate is somewhat higher than of radiofrequency ablation, and I'll show you some data in the next couple of slides. And at least in the series, it appears that a lot of these patients have undergone endoscopic resection, and it may need a tweak in its dosimetry as well. And indeed, from the first generation to the second generation, the treatment duration has been dropped from 10 to 8 seconds. And of course, except for RCT, except for RFA, we don't have any randomized trial data on any of our ablation modalities. So this was a multi-center study conducted at multiple institutions across the United States, total of 120 patients, of whom 92 were available for follow-up. And as you can see, the rates of CRD and CRIM are relatively high. Pain scores, again, it appears that cryotherapy of any kind seems to have less pain post-procedure than thermal modalities. This has also been shown in a comparative study with cryoballoon ablation. And as I said, in this study, the stricture rate was 12.5%. There was 1 perforation after a dilation, 1 GI bleed, and 1 hospitalization. Now, this is just hot off the press. This is a paper that we looked at. This is perhaps the first non-randomized but propensity score matched analysis, wherein we compared the histologic outcomes of 85 patients undergoing cryoballoon with over 200 patients undergoing RFA at 2 medical institutions. And we specifically looked at histologic outcomes, CRIM and CRD rates. And as you can see, at least on univariate analysis, it appears that the cryoballoon group reaches CRIM quicker and at a higher rate than with radiofrequency ablation. But on a multivariable analysis, which was also confirmed on propensity score analysis, the modality of ablation did not really predict the rate of achieving CRIM. And indeed, no surprise, the longer Barrett segments predicted a later achievement of CRIM. And if you had prior endoscopic resection, you reached CRIM faster. So again, this is the first comparative histologic outcomes paper between these 2 modalities. Last modality I want to touch on is hybrid APC. And here, a submucosal fluid cushion is first injected to reduce the depth of tissue damage. This was actually shown to reduce the risk of stricture formation in an ex vivo model. And essentially, you mark the area you want to treat, you inject the submucosal fluid cushion, and then you can actually treat with APC. This is relatively high energy dose. You scrape the necrotic tissue, and then you retreat at 40 watts. And again, this is a series that was published a while ago. 82% or close to 80% got histologic remission with a fairly low stricture rate. And indeed, this could be an option for patients who have failed RFA. It has also been used as a de novo Barrett's ablation modality and has done well in trials in the United States. And I believe a clinical trial to compare this modality with RFA is in process in the United States. So in conclusion, ESD is an alternative to CAP EMR. It has a steeper learning curve. It is safe in expert hands. It is somewhat limited by the fact that there is no specific billing code for it yet, but I believe one is in process. And as I said, comparative outcomes still need to be defined. And we did talk about the newer ablation modalities, which could perhaps be used either de novo or perhaps in patients with RFA failure. And I think randomized data is needed for defining their place in the Barrett's endotherapy armamentarium. Thank you.
Thank you so much for that talk. It really was a whole spectrum of treatment options. It's just amazing to see the newest technology that's coming out, the new tools that will be available to us. And thankfully, we have fantastic collaboration across, not just across the United States, but across the country to really get our study numbers up, because obviously it's numbers and multi-institutional data that really is going to help kind of drive decision making. So thank you both for your talk today. I'll start with some directed questions. I'll start with Dr. Kaul. I had a question kind of going back to at the most basic, when you were describing techniques for cap and band EMR. Obviously these devices and these technologies have a very finite tissue purchase. You're only going to get X amount of tissue when it's pulled up into the cap, the pseudo polyp as you described. So I guess my question is, after you have that resection with these types of technologies, do you kind of go back and reassess the margin of mucosa that's left behind, or to kind of determine if there needs to be more therapy around this area? Or do all these trials that talk about multimodal therapy pretty much just say, if we're doing band and cap EMR, we just have to do multimodal therapy? You do that little pseudo polyp resection and then hit it with ablation or something else?
Yeah, that's an important question. As I highlighted early on in my talk, I think resection is an important tenet for raised lesions. And typically after the EMR or ESD site is healed, especially in long segment cases, you do need to go back at a defined interval, which typically ends up being around about 6 weeks or so. And you go back and you ablate the residual mucosa, which is at risk. We have previously, just as a proof of principle, showed that EMR and an RFA, or EMR and cryo, can be done at the same session. Obviously, as long as you're far away from the defect site, as submitted as an abstract, presented as an abstract several years ago at DDW as well. But it's important to go back and ensure that the residual Barrett's is treated effectively and completely. The important point at the time of resection is that the index resection really represents the best time to resect everything that you can resect, because scar tissue does develop almost unanimously after any dissection, and going back and doing resections subsequently can be more challenging. An important point to be made here is that it's the depth of the pathology that's more important than the lateral spread of the pathology, which is why I think the case can be made is that both if cap EMR or band EMR for that matter and ESD get to the same depth ostensibly, then the point is moot, because if it's T1B on either pathology, then you have a problem. If it's T1A and the margins are clear, then you've achieved your goal regardless of which approach you've taken.
Yeah, that actually kind of tells me into a question that I had going into the topic of ESD versus EMR. And I guess I'll tail my question off of one of the studies that was presented by Dr. Iyer, and it was one of the exclusion criteria that you pointed was that they said no massive submucosal infiltration. So I guess my question is, you're planning on doing therapy, you're planning on doing endotherapy, your scope's in. It's like, how do you really know that there's quote unquote no massive submucosal infiltration ahead of time? Because are you going to know that before you start cutting? Presumably you're going to make your decision ESD versus EMR technique before you start cutting, whether it be one of those two techniques. So, how do you have that kind of predictive knowledge of submucosal infiltration? And I guess I would ask the question to either speaker.
Yeah, I think a lot of this is dependent on the appearance of the lesion. So there are certain appearances which are more suggestive of submucosal invasion. So I would refer to the Paris classification here of lesions, where if you have a type 2C lesion, which is sort of a slightly depressed lesion, you are likely going to see some submucosal invasion. Now, I think what they meant by massive submucosal invasion would be almost a type 3, which is ulcerated. And in that kind of lesion, you're likely going to see, definitely going to see submucosal invasion, and maybe even muscularis propria invasion. So those would be sort of characteristics. You can also, studies have shown that there are type 1P lesions, which may also have submucosal invasion, but massive submucosal invasion, I think, would be if the whole lesion is depressed and you just don't have any flat or elevated lesion. A second way of looking at it would be if you inject and the lesion does not lift at all. That to me tells me that this is perhaps deep into the submucosa or maybe even into the muscularis propria. So it's probably even a T2 lesion. And then the third thing would be, it's harder, but endoscopic ultrasound can give you a sense. It is not the end all and be all. Studies have shown that you should not rely on EUS experience to denote whether you have mucosal or submucosal cancer. But if you're obviously seeing muscularis propria invasion on endoscopic ultrasound, then you're probably going to be very careful before you start resection.
I agree with that. I think the injection and lift or the non-lifting sign can be very equally useful in the esophagus as it is in the colon. And EUS for 2 centimeter or larger lesions. Certainly most lesions that are that warrant CAP EMR or ESD, I believe are larger lesions that EUS may play a role. And again, EUS, there's a lot of literature on EUS staging for esophageal cancer. It's relatively harder in early stages for EUS to differentiate mucosal versus submucosal invasion. My rule with EUS is that as long as I can see a free and clear muscularis propria layer, it's a go, because the final distinction between submucosal invasion or not is pathologically determined, not imaging determined at this time. Now, this is an area where AI may actually help us down the road, but I think all of these parameters are used in conjunction to determine resectability.
Steve, you raised also a good question, if I can take you back to this EMR versus ESD question. And, it's this technique, as I mentioned in my talk, was really popularized by the Japanese. And they have actually conclusively shown that if you do piecemeal resection versus en bloc resection of squamous neoplasia in the esophagus or even in the colon or even in the stomach, you are less likely to see recurrence, which makes sense. Now, the critical difference between the squamous neoplasia in the esophagus or gastric neoplasia or colon neoplasia versus Barrett's neoplasia is that in Barrett's, we never stop at ablation with resection. We always follow with ablation, which is sort of our second modality. So to me, at least, it wasn't really clear what is the added benefit of doing en bloc resection of cancers if we are going to continue with ablation anyway, which is the reason why we looked at that question. And at least to us, at 2 years, the histologic outcomes of CRD, CRIM are not necessarily very different. The unanswered question yet is, what happens for recurrence? And I think that is data that we will have to accumulate and look at. There is a paper from the Cleveland Clinic where they have reported that patients with Barrett's who undergo ESD actually recur less than those who undergo EMR and are followed by ablation. So I think that data needs to mature a bit, and that will help us figure out what does ESD add to Barrett's endotherapy.
Right, and I think it goes back to the point of how well you do any technique. So it applies in the colon, it applies in the esophagus. If you're doing high quality EMR and ensuring that you've resected all resectable tissue at the index procedure, then the chances, and follow it up with ablation, then the chances of recurrence are as minimal as you can expect with the current interventions.
Absolutely.
So I think the techniques, the attention to detail, the quality of the intervention is really very, very important, as it is in the colon as well.
No, and as Vivek has shown, the bar is very high already. So, with cap-assisted EMR followed by ablation, we are achieving high rates already. So I think it's going to be very tough to show an incremental yield on top of that. So ultimately, I think it's really the size of the lesion and maybe the endoscopic appearance that is perhaps, as I alluded to, best suited. If you have larger lesions, you're suspecting submucosal invasion, maybe though, and there is scarring. I think those would be areas where ESD may have a bit of a role.
There is also the concept of the nature of the patient and other factors that contribute to recurrence, the genetics of this whole business, and there's a particular patient that is more prone to recurrence no matter what you do, and we have learned a little bit about that, but I think the genetic basis, the nature of the pathology at hand is very important.
Absolutely.
Yeah.
I see a question. I see a few questions in the
Yes.
Q&A box. Do you want us to address those, Stephen?
Yeah, please tend to the audience
Okay,
questions.
so there are 3 from Dr. Fanous, and I think maybe we will just alternate. So the first question is, how do you confirm eradication? Do you need a special scope? So for me, anything in Barrett's, there are always 2 things. You have to look and you have to do histology. So confirming eradication is basically you pass the endoscope. You would always buy a special scope. I think any high definition, high resolution endoscope would be good. I think if it is equipped with some kind of electronic chromoendoscopy, I think you are golden. That could be narrowband imaging if it's an Olympus scope. It could be BLI, it could be FICE, it could be iScan, depending on the kind of scope you have at your center. You should have a high definition monitor. I think you should clean the esophagus well, and you should spend some time. How do you confirm eradication? I think eradication would be confirmed by visual inspection. There should be no evidence of columnar metaplasia in the esophagus. And I tend to biopsy, once I see that there is likely no visible evidence of Barrett's, I will take biopsies in 2 separate bottles. I will biopsy in the G junction, the top of the gastric folds, and then I will biopsy in the area where the Barrett's used to be. And at least for us, eradication of all intestinal metaplasia is when the pathology comes back as the absence of intestinal metaplasia in the gastric tissue as well as in the esophagus. There is some debate on whether you need to do that at one time or whether you need to show it twice in succession. I like the twice in succession because that means that my treatment is truly more effective, but I don't think that's a unanimous opinion in the field. I'm going to turn the next one over to Vivek. Do you ablate 10 centimeters of non-dysplastic Barrett's in absence of other risk factors?
Of course, you turned the controversial one to me. But just, I to the previous question, the 2 consecutive negative biopsies, it used to be forceps biopsies up until a while back. But in our 11-year follow-up, it's interesting, time did not allow me to go into too much details, but nearly half of the patients in follow-up in that 6-year period, nearly half of them had dual modality tissue sampling with 2 consecutive dual modality negative samplings. And the second modality, of course, is wide area transepithelial brush biopsy, which is an artificial intelligence infused individual assessment at an outside center. So I think that the confidence in eradication up front is the investment we need. And I think that forms the basis for our assurance that the long-term recurrence will be low. In terms of non-dysplastic Barrett's, in my mind, as the guidelines have clearly elucidated, it remains a surveillance paradigm for the most part. I have ablated patients with non-dysplastic Barrett's regardless of their segment length. When it comes down to, are there any familial or historical factors at play? So if a patient comes in with 2 other first-degree relatives with Barrett's and 1 or 2 relatives with esophageal cancer, especially at a young age, that's a very strong motivator. I had a patient recently whose 21-year-old son had esophageal cancer, and the father came with long segment Barrett's. Of course, he had dysplasia, but even if he did not have dysplasia, I would have probably leaned towards ablating that. But for the most part, I think this remains a surveillance group. Now, if you do end up ablating non-dysplastic Barrett's, I would submit that the documentation of the shared decision-making and why you actually deviated from the guidelines, as long as you have that in place, I think that's a very good safeguard. God forbid if things go wrong from a procedural complication standpoint. So that's how I would address that question.
I think that's an excellent approach, Vivek. I also take that opportunity to actually do a very careful exam on white light and narrowband imaging, or using any kind of chromoendoscopy, biopsy as per the Seattle protocol, and in many instances you will actually find dysplasia, which automatically makes that person a candidate for endoscopic eradication therapy.
Right,
And
sorry.
the few people that I have ablated, despite having no dysplasia, are those exactly like the ones that Vivek is describing, which is family history of Barrett's or esophageal cancer. So familial Barrett's would be another.
And I think this is an area where, as you mentioned, we harken back to the quality of the esophageal exam with Sachin Vani's work on that was very important. And just like we've talked all these years about the colonic examination, I think the same paradigm should be used here. And I think to be fair, we're looking for an excuse in such patients who are already at some degree of risk. And even if a long segment has multifocal low-grade dysplasia, the case is then made, and as I mentioned earlier. And next question, sir.
Next question is, in case of low-grade Barrett's with large hiatal hernia, what do I do first, ablate or surgery? So this is a common conundrum. So I'll tell you what my approach is, and Vivek may have a different approach. But even though studies have shown that the size of a hernia could be a predictor of response, though it's not a consistent feature, at least in our series, it was not. I still feel that the success rate that you have with medications is high enough that I don't feel the need to actually correct the surgery before I ablate. I have had successful results with large hernias, even approaching 10 centimeters. So I typically will educate the patient. I think education is very important. You need to have them follow a diet. You need to have them be compliant with their medications. You need to put them on twice-a-day proton pump inhibitor therapy. They need to take it at the right time, in the right dose. I will sometimes add a bedtime H2 blocker. And under those circumstances, I would say that the response rate, regardless of hernia size, is fairly good. I would say upwards of probably 70 to 80%. So I don't see the need to proactively reduce every hernia, because otherwise I'd probably be sending a lot of my patients to surgery. Now, Vivek he did mention this issue of lack of response. So that's where I would be carefully evaluating the patient. Are they responding the right way? Particularly if they have persistent esophagitis, despite adequate therapy, they are compliant, you've educated them, or they are not responding, whatever definition you use, less than 50% response after 2, or any Barrett's or any dysplasia after 3. If you see those things, then I begin to think about surgery. Now, I don't jump to surgery typically. I usually, at least at our institution, the surgeons will want some kind of demonstration, an objective demonstration of the fact that on maximal medical therapy, your acid reflux is not well controlled. So I will do some kind of ambulatory pH testing. And if you demonstrate on ambulatory pH testing, on medications, that the reflux is not controlled, then I think you make a strong case for surgical intervention. So I'll leave it there.
No, I agree. And I think the vast majority of hiatal hernias do not interfere with treatment. Every so often, a patient will come along that it's pretty clear in follow-up that this patient is not progressing. And at least the conversation has to be invoked at that point. And a lot of these patients have very difficult distal esophageal disease that may or may not benefit from hernia repair, but that's a different discussion. It's not a common problem in clinical practice at this time.
Yeah, I would ask the question again in the spirit of combining our gastroenterologists and our surgeons in the society, is asking the question on the other side of the coin is managing these patients post anti-reflux surgery, whether you knew they had it ahead of time, they went on and got anti-reflux surgery and they're still dealing with it, or they recur, or they had anti-reflux surgery and now they're low-grade dysplastic patients. Does your algorithm change? Does your management change if they're post anti-reflux surgery patients?
Not really.
Not really. No.
I think you would follow the same principles.
I should mention that there are very rarely patients who are genuinely allergic to PPI therapy. I've had a couple of those over the years. These are genuine, documented allergic reactions to PPI. Short of PPI, really, it's very hard to control long segment treatment-related injury, and or concomitant acid exposure. So those are special situations, but that's not a common scenario.
So to talk a little bit real quickly to try to round out this fantastic talk tonight, talk a little bit about the new technology that we talked about. So Endo Rooter, this is obviously, as a surgeon here, I've never seen it, never really heard of it up until tonight, but I gotta ask, what, in your opinion, what type of lesions is this the best for? Is it flat or ulcerated lesions rather than nodular regions? Lesions. What do you guys see as the benefit over other modalities for the Endo Rooter?
So Prasad, you can go ahead and make them chime in.
No, that's fine, Vivek. I guess, I would hesitate to take out a nodular lesion with the Endo Rooter. I would like to actually resect it if at all possible. My sense would be to use the Endo Rooter for maybe lesions which are relatively flat but are not responding. And there you can actually sort of, just little by little, you're whittling away at the lesion, really. And it's the blade is circling. Now they do recommend injection, submucosal saline injection to protect the muscularis propria. So again, I think my preference would be to not use it for nodular lesions unless you are stuck in a situation where the patient understands the risks. They don't want any surgery. You've tried other modalities. You've tried ESD, and this lesion is not just amenable to endoscopic treatment. There, perhaps I would use it for a nodular lesion.
Yeah, I think I agree with that. So we have had early experience with the Endo Rooter. In fact, part of a randomized trial between Endo Rooter and the other ablation modality, where it's primarily being used to treat refractory Barrett's related to that original modality. And the treatment is limited to potentially residual flat Barrett's and or scarred mucosa that is not amenable to standard therapy. And it's a randomized crossover so that you can either go to the same ablation or go to Endo Rooter for 2 attempts. We had a recent publication in GIE on Endo Rooter with Barrett's, duodenal lesions, and colonic lesions, where it showed where it actually can help. So the Endo Rooter does collect tissue in a cartridge, but that tissue does have some architecture, but it's not an EMR specimen or an ESD specimen. So that's to be noted. It can tell you between cancer or no cancer, high-grade dysplasia or no high-grade dysplasia, but it doesn't really have the formal architecture. So for raised lesions, EMR remains or ESD remains the best option.
All right, well, thank you so much for just getting over our hour here. I really wanted to thank our speakers so much. I couldn't have asked for 2 better speakers on such an important topic. Again, the American Foregut Society is so happy to represent collaboration between surgeons, gastroenterologists in such an exciting field. There's so much new technology, new research, both in endoscopic therapy and surgery as well. So thank you both for covering such an exciting topic. Thank you to everybody who's tuned in and participated throughout this whole year. We have certainly a good, exciting calendar coming up for 2022. I hope everyone has a safe and happy holidays and a happy new year. And thank you both for your time tonight. So have a great evening.
Thank you, Steve.
Thank you very much.
Bye-bye.
Bye.
Bye.